Welcome to the Peds Hub podcast.
We are a group of paediatric trainees in the Southwest who every month review a selection of articles that we find useful for our practice.
These are taken from the BMJ, Archives of Disease in Childhood Journals.
For the full articles, please go to their website, journals.bmj.com.
Please note, these are our own opinions and are produced for educational purposes only. They are not intended to substitute professional medical advice, diagnosis, or treatment.
Thanks for listening.
Hello again, I'm Bex. I'm a PEDS trainee currently out on UPI. I'm going to talk about one article this week, keep things short and sweet. It's from October's edition and it's a review article entitled Do You Know When the Inhaler is Empty? By Fullwood and colleagues who are part of the West Midlands Paediatric Severe Asthma Network. We all know the importance of reviewing inhalers each time a child with asthma attends a clinic appointment or gets admitted with an acute exacerbation. It's drilled into us to ask about adherence, review the inhaler technique, including whether the child is using a spacer, and then to go up or down on the asthma treatment ladder depending on their symptoms. But how frequently do we ask if parents or children are tracking how many puffs they used from the inhaler? And how would they know if it was empty? In fairness, I didn't know the answer to this either, so I certainly can't expect a kid to know it. Meter-dose inhalers are the most common inhalers prescribed and frequently do not contain a dosing counter in the UK. Within the canister is a mixture of the drug and the propellant. Roughly, but obviously it entirely depends on which inhaler you're using, there's 200 actuations within there that actually contain the drug. The article suggests that the last 86 after those 200 of a regular MDI will contain no drug whatsoever, just propellant, which is really unnerving. You can see how in an acute exacerbation of asthma, just inhaling propellant is utterly pointless and could put the child's life at risk. You may have seen that some of the preventer inhalers do contain a counter, but it's certainly not universal. The article notes that there is no clear warning about this on leaflets, either supplied with the inhaler. The majority recommend counting the puffs and making a note each time it's used, or weighing the inhaler routinely as the medication is used up. Other methods that appear to be routinely used by patients include shaking the canister, giving it a spray to see if a puff appears, and if you Google it, some websites even suggest floating it in water, and if it floats, it's empty. None of these methods are actually accurate in ascertaining if the medication has run out. This was a quality improvement study that collected data on a total of 157 children who were prescribed inhalers for a range of conditions, including asthma, preschool wheeze, cystic fibrosis and bronchiectasis, and they were all attending their routine outpatient appointments. During the consultation, the child and the family were presented with a salbutamol inhaler that was empty of medication, but still had propellant within it, and asked how would they identify how much medicine was in the inhaler. The study also took note of any inhalers that the child brought with them that did have a dose counter, and they recorded the number of actuations left on the dose counter. The study finally reviewed leaflets from the commonly used inhalers to look at how manufacturers help patients identify an empty inhaler. Interestingly, over 50% of participants felt that they would know if their inhaler was empty. When all 157 of the children and families were asked how, 70% shook the inhaler to feel for the medication, and 30% sprayed the inhaler to demonstrate aerosol. Of all the families, only 3 said that they would check the dose counter, and 2 said they wrote down the number of puffs used each time. When the families were presented with the empty salbutamol inhaler that still had propellant within it, 75% of participants thought it contained medication, and some even thought it was full. When the team then reviewed the patient's inhalers that contained a medication counter, nearly 20% read 0, i.e. they were empty and still being used by the patient. Finally, when the information leaflets were reviewed, there was no information for the inhalers that did not have a counter on how to identify an empty inhaler. Similarly, there was nothing on the NHS or Asthma UK websites. The paper concedes that counting the number of doses used is an impractical way of knowing when the medication has run out, but it's currently the only way of ensuring you're actually taking the medication. I think this paper puts forward a really strong case for ensuring that all inhalers contain a counter in the future. If we are prescribing an inhaler that does have a dose counter, then highlighting this to the patient so that they know when to discard the inhaler should be part of our consultation with the patient. I'm currently working in Australia and all subutmoral MDIs have to have a dose counter. But again, as this study highlights, the dose counter is only useful if patients and their families remember to look at it. Really interestingly, and perhaps a little bit beyond the scope of the paper, it also mentions about the environmental impact of metered dose inhalers. Specifically, when the study participants were asked how to dispose of the inhaler, most just put their used inhalers in the standard bin. Actually, it turns out that all inhalers should be taken back to the pharmacy in the UK for proper disposal. This allows them to be incinerated or recycled. This has led me to read a little more about the environmental impact of inhalers in general. The common pressurised metered dose inhaler we prescribe contains hydrofluorocarbon propellants, which are greenhouse gases. These therefore contribute to global warming considerably more than dry powder or soft mist inhalers. Now, for a young child, less than 12 years, or in an acute setting, a pressurised metered dose inhaler is most likely going to be the most appropriate inhaler to prescribe with a spacer. To use a dry powder or mist inhaler, you need to be able to coordinate a long, fast and deep inhalation. But for a compliant older child, you could consider the suitability of a dry powder or soft mist inhaler. Ultimately, one of the best things we can do to reduce the use of pressurised MDIs is prevent exacerbations by ensuring we have optimised the preventative treatment for their asthma. So to summarise, when reviewing inhaler technique with patients and their parents, discuss tracking the number of puffs used within an inhaler. On average, the last 86 puffs of a subutmoral pressurised metered dose inhaler will contain no medication within it. Prescribe inhalers with counters, if possible, and as a profession, we should advocate for legislation that enforces pharmaceutical companies to include dose counters on their inhalers. Advise families of disposing of inhalers at a pharmacy and not in the general waste bin. And then finally, for older, more compliant young people, consider prescribing dry powder as soft mist inhalers if they can demonstrate good technique with these. Thanks very much for listening. That's all from me.
That's all for this episode. As always, if you have any questions or comments, please feel free to get in touch via our email address podcast@pedshub.co.uk or via the PedsHub website. Equally, if you'd like to get involved, we always welcome your voices, so please do get in touch.
Thanks for listening.